side to side, okay? We're gonna learn two different techniques for moving the patient side to side in bed. There is the USA way, and there's a textbook way. Either way is appropriate. It's all based on your preference, size of the patient, what you feel comfortable with, where they are in bed, okay? So, first technique that we're gonna learn is going to be without the pillow. The second technique will be with the pillow, okay? So again, let's see, I'll move towards them.
You want me to roll?
No, just stay up some fun. Okay, so we got the patient back to bed. She's all the way up against that bed rail. I want to get her centered in bed because I'm about to leave her. So I need to be able to move her side to side in bed. Again, where should the bed height be? Hip height. Okay, and it's going to vary based on how far across the bed that patient is. If they are all the way across and I'm reaching, so like my hip is up against that bed and I'm hands on the patient, do I want the bed higher or lower? Lower, that way I can reach without having to like have her up here at my shoulders, okay? If you are hinging forward, that bed height comes down with you. Okay, it's gotta feel comfortable to you. So on your competency, I wanna see that you've addressed the bed height and that you feel comfortable with where it's at, okay? Within this area, okay? If it's down here and you tell me you feel comfortable, we're probably gonna have some problems, okay? Around the hips is where we're shooting for. So this is a little bit lower than my hip, but I feel comfortable reaching across to put hands on the patient, okay? So first technique we're gonna learn, taking the pillow away. So you remove it, thank you, okay? So we did our soft hands. We went down with the thenar eminence, wrapped around. First bony landmark was scapula. That's gonna be our bony landmark here for the upper trunk. Lower trunk, bony landmark is gonna be the hips. And then the legs, you'll just move them simply over, okay? So 3 different movements. So patient's arms, again, across her chest. Legs, we'll assume that they can't lift them themselves to move them side to side in bed. Obviously we're gonna be basing these movements off of a patient that's unable to do the movements that we're doing for them, okay? In clinic, in the hospital, you have a variety of patient abilities. We're always gonna encourage them to do what they can. So if my patient can walk their legs to the side, I'm gonna instruct them to do so, okay? But we're gonna assume for this patient, they're unable to, just to teach the technique. Patient's head, again, count of 3, I want you to lift your head, help me as much as you can. So they can kind of side bend, they can crunch, they can do what they are able to do to get some activation to help, okay? So again, I'm gonna reach, my stance is now, so before we're AP stance, we're still gonna be AP stance, okay? But instead of being parallel to the bed, moving up and down, I wanna be facing the bed because I'm moving the patient from far away, moving them towards me. We're always moving patients towards us, we're never pushing them away. One, pushing creates more shearing, it's not gonna feel comfortable for the patient, and there's the potential that you push them where? Too far, out of the bed. Even if the railing's up, I've seen railings drop when a patient bumps into it. Patients could go up and over if they're TBI, if they're exaggerating any kind of movements. So patients always move towards us. Okay? So I'm at the trunk, AP stance. It does not matter which leg is forward because either way, my hips are facing the patient. Agreed? So here or here, it's whichever feels most comfortable to you. For me, I like my left leg forward for some reason. So leg's gonna go forward. That's my stance leg, which means it's going to be straight or bent? Bent. That's going to be what I'm driving off of. I'm weight shifting backwards. Arm's going to go across, under shoulder, shoulder, and I'm underneath. Okay, I'm not here on the side. I'm not clamping. Underneath, underneath, and I'm back. So I'm stance, as my weight is on my front foot. My back leg, if you guys can see, is quite far back because I'm going to weight shift onto it. And we're going to move towards me. Lift your head on 3. 1, 2, 3. We move over. Just moving far to exaggerate the movement, but obviously you would end in the middle. Okay? Come down to the hips. Same thing. Here, here on the hips. Help me if you can. 1, 2, 3. And it's a weight shift. I should see your arms bending and moving because that tells me you're not weight shifting, you're not following proper body mechanics. Legs. 1, 2. Or if you want to keep the technique, AP stance, you have to go distal to the knee because if you go under the knee, they're just going to bend, right? To lock them out of extension, and then you could move over. Some of your larger patients, they aren't as easy to move the limbs, that's gonna be your technique. Or even one leg at a time, depending. Okay? That's the first technique. Go ahead, move back. So that is the USA way. That is the way that I prefer to move the patients sequentially. Textbook way, keep the pillow in place, where it's only gonna be 2 movements. So it's going to be my arms underneath the patient's head, underneath the small of her back. Again, weight shifting, moving her sideways. Come down here, underneath the small of her back, behind her knees, weight shift. 2 movements, okay? You get to choose whichever one you feel most comfortable with. Anytime we're putting a hand underneath a patient, be mindful of jewelry. I'm gonna take my watch off, as I will not feel comfortable underneath her back. All right, anytime you're putting a hand under a patient, we wanna go palm down. Palm down allows you to push into the mattress, compressing it, so that again, there's less shearing, less rubbing on the patient's skin. Okay? So, AP stance, again, I'm gonna keep my left leg forward, it's my stance leg. My hand through, palm down, and then on the other side, I'm gonna rotate palm up so that I can hold on to the pillow. Here's gonna be her hip, okay? Palm facing down, if they can arch their back, by all means have them do it. And then this side I rotate up. Okay, count of 3, I'm gonna move you towards me, help if you can. 1, 2, 3. She moved over, take your palm out. Now we're moving down, small of the back, behind the legs. So palm facing down, through the back, on her eye teeth. Here, here, AP stance. 1, 2, 3. You can go move. You can sit up. She should feel like she's gonna fall off. Okay? That is the textbook way. Pillow in place versus pillow removed. Okay?
I feel like I could assist more with the first way.
Yeah, because it's
than
sequential versus you're moving more of the patient's weight. So obviously segmentally, 3 movements, you're gonna be moving proportionally less of the patient's weight, a little bit easier if they're larger. And like she said, she feels like she can help more with that. Versus this one may be for your smaller patient that you can manage more of the patient's trunk, and maybe they can't help quite as much. But either way, whichever one you like, practice both, and then we'll come back together. Any questions? Okay, remember, AP